Friends, welcome to the Tuesday evening critical care and emergency sessions from Yashoda Group of Hospitals. Every week, we bring some interesting topics which are based on some controversies or debates on some areas which are of more interest to the clinicians. So this week, we thought of a topic where many of our intensive care specialists are in that way. Many of our clinicians across the globe and across even India thinks that the end-stage lung disease, patients who are disabled by effort intolerance, hypoxemia, needing oxygen with some of the end-stage lung diseases like your interstitial lung disease, then your bronchiectasis, and then some of this end-stage lung fibrotic conditions from also post-COVID has been a end of the life or end of the road, because many of our clinicians do feel that the lung transplant is still in a very primitive or early part of its inception in Indian context. So over the last 2 years, with all the efforts of the team in Yashoda, we could brought some interesting case series where the patients from a disabled and crumbled state has brought back to the normal life. And we have a very excellent team of both transplant surgeons, transplant pulmonologists, and transplant intensive care specialists. And nevertheless, the whole team, including the city's transplant anesthesiology and the team of intensive care nurses in and around. So all of them has put their efforts to bring this success. So today, I request Dr. Charan, who is our transplant intensive care specialist, will bring us those 12 cases which we actually done over the last year and so. And Dr. Jnanesh Thacker, who will be our transplant surgeon, will bring us the insight into this transplant program in Yashoda and give us an overview where we stand in India and all that. So to start that, I request Dr. Charan to bring the case series. Over to you, Dr. Sri.
Thank you, sir. Now we'll be actually discussing about the success series of lung transplant in our hospitals. So with keen interests in excellence in the field and advancements of excellence and the advancement in the field of medicines, the Yashoda Hospitals management under the leadership of Dr. Pawan Gorukanti established a heart and lung transplant unit, gathering some of the most renowned professionals in the field of transplant medicine we know so far. Like any program in its inception, it has gone into a shaping and optimization, and it is where it is now, and it has been morphed into an area of excellence it is now. In the middle of the pandemic, that is in the October 2020, we have actually established a heart and lung transplant unit, and we did our first heart transplant 1 month after its inception, namely in the November of 2020, and we did the first lung transplant in 3 months after its inception. The program has been running successfully ever since. So here I am actually trying to present a case series of successful lung transplants, which we have done in our institute. So this, our first case, this is the first ever case of lung transplant which we've done in our hospital. So this is the first case. He's a 45-year-old police constable whose life turned upside down when he became oxygen dependent and bedbound with end-stage lung disease with ILD. He could not discharge his professional duties anymore. Even his daily activities became restricted, and he was awaiting a miracle. And he was given one in the form of a bilateral lung transplant. And his zeal to live a normal life actually enabled him to have a miraculous recovery. He was liberated from mechanical ventilation and he was extubated on day 3 of surgery. And he was discharged within 2 weeks. So this has been a very quick recovery so far. And he has been in constant follow-up with our team of professionals. And he has since joined back his police service. And he's thus helping making this world a better place, if we can say. So this is the patient with whose this is the lung on which we had to operate, and he had to subsequently undergo a bilateral lung transplant for this end-stage lung disease. And he's now completely off oxygen, a police constable, chasing criminals and making this world a better place. Coming to the second case. So second case is actually a 19-year-old engineering student. So In the prime of his youth, he was diagnosed with end-stage lung disease and due to cystic fibrosis. The once energetic boy became oxygen dependent and BiPAP dependent and was having repeated visits to hospital because of repeated acute exacerbations. There was significant restriction in his activity, and he underwent a bilateral lung transplant, and he was positive about his life throughout his stay, so which actually enabled him to make a super fast recovery. And he was extubated from ventilator on the second day, and he was discharged on the 16th day of his surgery, post-op 16th day of his surgery. So this is the lung which we have operated upon, the cystic fibrotic lung multiple system. And this is him now rocking on with his friends after his surgery. So it's been a year since he has completed his surgery. He's doing quite well. So there comes a 36-year-old businessman. He fell prey to the deadliest pandemic of this generation, namely the COVID pandemic. And there was bilateral, extensive lung involvement. So, and he became completely dependent on high requirement of oxygen support. So he was on continuously 15 to 20 liters of oxygen support, and he was in hospital for many days. Days turned to weeks and weeks turned to months with no hope of recovery in sight. So he was subsequently listed for the lung transplant, and he underwent a bilateral lung transplant in the middle of 2021. However, his prolonged hospital stay and severe movement restriction have taken a toll, and he required post-operative ECMO for a short period of 5 days, after which he was decandidated of ECMO, and prolonged mechanical ventilatory support, for which he was tracheostomized and he was given long-term acute care therapy, and he was subsequently rehabilitated, with which he made tremendous recovery. He was decannulated of the tracheostomy 40 days after his surgery, and he was discharged home at the end of 48 to 50 days. He is currently off oxygen. He is enjoying a new life. He is driving, and he's having a quite productive life. Then comes a 47-year-old priest. So he was finding himself unable to breathe, and he was subsequently, and with the hospital visits, he subsequently came to know that he was diagnosed with a quite rare condition called pulmonary alveolar microlithiasis. So this rare condition was actually causing him to be more breathless, and there was a great increase in the amount of oxygen that he requires, and he was offered a bilateral lung transplant as a therapeutic option. So he was subsequently underwent the transplant, and he made tremendous recovery. He was extubated on the 5th day, and he was subsequently discharged on the 14th day. He's a very active man. Preoperatively, he remained active during surgery, and he is presently active immediately post-op also. Presently, he's not requiring any oxygen, so he is on room air ever since the surgery. So this is a case of pulmonary alveolar microlithiasis CT, and this is him now without oxygen. Then comes a 35-year-old and his family. So we're shocked to find out that he was actually suffering from a progressive lung disease, so which is causing him to become more and more oxygen dependent and BiPAP dependent. And he subsequently underwent a bilateral lung transplant because this is the only therapeutic option. So he was subsequently liberated from mechanical ventilation on day 5, and he was actually extubated onto NIV because of his chronicity of illness in the interstitial lung disease. However, his post-operative course was complicated by an infection, which makes itself more common and deadly in these times of immunosuppression in the initial phases of during the initial time post lung transplant or post any transplant for that matter, because of therapeutic immunosuppression. So which caused him to actually deteriorate a bit, and he was actually reintubated on the day 6 post-operatively. But he was managed with timely blood cultures and timely appropriate antimicrobials. So his condition responded very well to the said antimicrobials, and he was subsequently extubated on post-operative day 9. And he made a very good recovery, and he was discharged off oxygen on post-op day of 25. So this is him, and this is his lung preoperatively. So after lung transplant, this really did make a difference, and he was completely off oxygen, and he is able to go about his daily activities without any problem. Now coming to the other case, this is a 34-year-old male marketing professional. So he became gradually oxygen dependent and BiPAP dependent, and he was unable to play with his beloved son because of his end-stage lung disease brought about by bronchiectasis. So he was requiring 6 liters of oxygen, and he was largely confined to a room, and there is a significant restriction of his daily activities. So as a therapeutic option, he was actually offered a bilateral lung transplant, which he underwent, and in late 2021. And he made an excellent recovery post-operatively with extubation on the day 4 after surgery. And the entire post-operative course was without any complications. And he was discharged successfully on day 17 post-operatively, where he's going on about his life, and he even joined back his job. He's playing with his son and is quite really happy about it. Then we have a 44-year-old homemaker, and she was actually having gradually progressive breathlessness, and she subsequently became completely BiPAP dependent with significant type 2 respiratory failure. Her PCO2 levels in the initial phases were in the order of 90s, albeit compensated, but she was completely and utterly BiPAP dependent, and she was growing breathless with every breath at the moment, even if you take her BiPAP, even for taking food, drinking water. So even the smallest of the daily activities have taken a large toll on her, given her lung condition. So there were repeated hospital admissions, and there is severe restriction of day-to-day activities, and she subsequently underwent a bilateral sequential lung transplant. She made an excellent recovery. There were no complications in the post-operative period. She was subsequently extubated on day 4 after surgery, and she was adequately rehabilitated. She did excellent physiotherapy. She was more enthusiastic about physiotherapy, and she actually really enjoyed her new lungs, I should say. And she's right now off BiPAP support as well as off oxygen support, and she's leading a very good life. So the next case is a 52-year-old homemaker. So she was oxygen dependent due to end-stage lung disease and because of ILD. She was dependent at 6 meters per minute, which she underwent a subsequently she underwent a bilateral lung transplant. However, she had severe primary graft dysfunction. The primary graft dysfunction is said to be one of the most common complications in post-operative period after lung transplant. And however, she was managed very effectively with a protocol-based mechanical ventilator management. And she was actually supposed to have ECMO as a backup. In worst-case scenario, we were actually planning her to put on ECMO. However, she was strong in her will, and she recovered without ECMO support. And she was brought back to normalcy by POD 5, where we were able to extubate. 48 hours after we were contemplating to put her on ECMO, she was quite well. Her lungs responded excellent, and she was subsequently extubated. Other than this, she did not face any other complications in the post-operative period, and she was discharged successfully on the 16th day of the surgery. So this is she, who with her very bad lungs preoperatively, which you can see actually in the CT beside, and right now she is off oxygen without any support. She's a successful homemaker now, looking for the entire family. She's doing good. This 39-year-old lady was dependent on high oxygen support, as high as 12 liters per minute during rest, and which was further increased to more than 50 liters during exertion. So she had quite a good stock of oxygen cylinders in her home. She had severe restrictions in her abilities, and she had repeated hospitalizations because of her debility and acute exacerbations. And she subsequently had a bilateral lung transplant. So she was successfully extubated on the day 5 of her surgery. There was no complications during her entire post-op care, except for an intermediate episode where she was having atrial fibrillation, which is quite common post-lung transplant, which was managed effectively. And she was discharged on the 17th day post-operative. So this is she with her. You can see the badly damaged lungs in the CT, and she is now today without any oxygen. In fact, she was discharged yesterday. So these are a few of our success stories, which I wanted to share with you all when it really comes to lung transplant and its recovery. So we have a couple of recovering cases right now. Both the cases of ILD who were actually operated upon in the last month. So both of them are making good recovery right now. One of the patients is extubated and he is on NIV, whose settings we are gradually coming down. Both of them are hemodynamically stable. So the plan is actually to bring them off NIV support and get them to more physiotherapy and rehabilitation. One of the patients is having some degree of primary graft dysfunction, which is being supported by ECMO, and he is recovering and is doing tremendous recovery. And we are contemplating on getting him off ECMO shortly. So these are our post lung transplant recipients, heroes, we should say. For their fighting spirit, they have actually shown us the path of how to actually go through during a phase in life which is difficult to pass through. But they kept their cool, they are always courageous, and they got it through. However, I should add that lung transplantation, like any other medical procedure, is associated with certain risks and varied outcomes when it really comes to the patient population. And we presented here some of our successful stories so far. Thank you.
Thank you, Charan, in bringing those success stories. I do understand right now the complexities involved in the major transplants, that too, particularly when it comes to the lung in Indian context. So it was such a gratifying and motivational, or such a completion of your feelings when you see a set of 10-15 post-transplant guys in the last 6 months to a year who has been undergone transplant, coming back, bouncing back to you with the jubilant happiness, celebrating their to get togetherness or togetherness with the family. That was such a heartwarming phenomenon in the Yashoda Hospitals in the last week or so. So I right now invite Dr. Jnanesh Thacker, who is the chief of the transplant program in Yashoda Group of Hospitals in Secunderabad. We welcome you, sir.
Thank you, Dr. Venkat. Thank you. I appreciate. Can you hear me?
Yes, sir. So there is now, if you look at the clinical part of this, the critical care clinicians, the pulmonologists across the India, and different other clinicians, they may come across these chronic lung diseases, and many of them still has that the mind blockage or inhibition that what is the current status of lung transplant in India? What are the chances that the patients will get a lung, and what is the chances that the patient will get recovery? These are the inhibitions which always are there with any medical therapeutics or in interventions. So you may say a PTCA when it is initiated, you may say a kidney transplant when it started, or you say liver transplant when it started. So these kind of initial tethering effects will go through any country, any healthcare system, and any organization. So we at the Yashoda Group of Hospitals, when we started this program around a year and a half back, when there was a mid of the pandemic, with the all vision of Dr. Pawan Guruganti and the whole team of the Yashoda management, when they brought this concept, we all were just trying to see how a lung transplant phenomenon will be a reality. And in no time, that was a reality. In a month's time, we started seeing a lung transplant patient walking out of the hospitals. Yes, it is as pointed out by Sri Charan, every complex kind of these therapeutic interventions or transplants will go through some turbulences, will go through both morbidity, mortalities, which is a part of any interventions of this complexity. But yes, what we are trying to probably look at is the number of successes which is happening is heartwarming, and we want Dr. Jnanesh Thacker to elaborate many on those areas. So first of all, we see literally that every organ is transplantable, provided you need how to, we know how to handle them. So right now we are very commonly doing renal transplants, hepatic transplants, and even cardiac transplant. And we also see that many of the other organs like cornea, you say the skin, you say the cartilage, you say many parts of the body has been reserved as in the banks and that been transplanted. So transplant has gone from a smaller organ to a larger organ in almost every part, probably not the brain, the rest all can have some or the other parts involved in the transplant. But we always find it difficult when it comes to lungs. So why do you think so? The lung transplant is something which is kind of takes its special place. Why we are a little concerned when it comes to a lung?
Dr. Venkat, Thank you for giving me the opportunity for sharing some of my thoughts with you. And I would like to say that there is a very interesting quote on the UNO's website, which says, lung transplantation is the most complex medical endeavor taken up by men. So lung is a unique organ. If you look at it historically also, on 2nd December 1960, on 3rd December 1967, Dr. Christian Bernard did the first successful heart transplantation. The first successful lung transplantation was done on 7th November 1983, which is almost 16 years after the first heart transplant, because of its complexity and because of its tenuous care that is required for lung. The technicality is, or technically also it is more challenging. In fact, it is more challenging than heart-lung transplantation, which was done first by Dr. Bruce Wrights in 1981. So heart-lung transplantation was done successfully before lung transplantation could be done. So Dr. Joel Cooper did the first lung transplantation at the Toronto General Hospital on 7th November 1983, which is where set the ball rolling for lung transplantation. Then in 1998, when the outcomes were not very good, all the learned pulmonologists of the world got together, the 5 major societies of the English-speaking world, and devised the guidelines. And after these guidelines were put into practice, the outcomes of lung transplantation started to improve, and more pulmonologists started referring patients to transplant pulmonologists for registering and listing patients. The outcomes started to improve. Then 2006, the guidelines were revised because the outcomes started to improve. And then in 2014, the guidelines were re-revised. The latest guidelines are revised in 2021. These are the latest guidelines. The lung transplant is different from all other organs because it is constantly exposed to the environment. And as you know that the surface area, if you spread the lung out on the floor, it will be equal to a tennis court, about 400 meters squared, which is constantly in contact with the environment. Therefore, chances of infection and infection-induced rejection are much higher than any other organs. Lung transplantation, surgery is complex. Preoperative evaluation is a little bit more complex than other organs. The donor evaluation is complex. Donor surgery is a little more complex. And postoperative care is also a little more complex than all other organs. So it is different. I hope I have answered all your questions. The outcomes, of course, the median survival of lung transplantation is 7.6 years compared to heart transplantation. The median survival is about 13.3. So almost half the lung, because it is constantly interacting with the atmosphere.
So now you spoke about as an organ, the lung has its own challenge. The exposure to the atmosphere, the transplanted lung, which is an immunosuppressed lung or the immunosuppression host, is continuously in exposure, maybe 20 times to the atmosphere. And the complexities of its immunogenicity, the complexities of its surgical skills needed. But again, as a country, we are complex. So what is the challenge, particularly when it comes to the lung transplantation and in Indian context?
Of course, in India, we have several challenges. Our hygienic habits, pollution in the air in several cities, the endemic infections, and lot of patients are economically challenged because they just cannot, it is because of the expense and the cost which curtails their access to. So at this point of time, many patients may be thinking that many physicians may be thinking that lung transplantation is an option for the economically affluent class of people. This is one of the challenges that we face as a nation, that we should try to make sure that we have transplantation given to all countries. I mean, all population of all, even the economically challenged. To work upon situations like education of the people for hygienic habits so that they don't spread diseases like tuberculosis and other infections. Of course, pollution, and we are doing all these things as a nation to reduce the amount of air pollution by increasing adult education. So this is one of the big challenges in the environment. The other challenge which is faced by us is that the pulmonologists are not very convinced about the outcomes of lung transplantation, and therefore their referrals are very late in the very advanced stage when the patients are nearly have no option and they are referred. So the outcomes are not very good. Understandably, we can understand that the pulmonologists are not sure of the outcomes of lung transplantation at this point in our country, since it's a new program which has just begun in 2012 in our country, where the first Indian got a successful lung transplantation in India. So considering that we have only a 10-year history of lung transplantation in the country, it is understandable that the pulmonologists have their own reservation of advising lung transplantation to their patients. But as they get more educated and they see more successful patients who are struggling for breath, getting back into normal life and living their normal life, I'm sure that they will be referring patients earlier, as some of the pulmonologists have now started referring patients as soon as they meet the criteria according to the international guidelines of 2021, which I just mentioned a minute ago.
So seeing is believing, sir. So what we have seen in the last 1.5 years, that our first post lung transplant patient, when came back bouncing, going back to his regular professional constable job and actively coming back to our programs, is something what actually makes us to believe. So as we all say, seeing is believing. But as you mentioned, as a lung, as an organ, it has its challenge. In the Indian context, with its continuous contact with such a challenging atmosphere, it has its own. With this kind of both the challenges as an organ, as a country, you managed to actually change the ball game in a different direction, Dr. Jnanesh Thacker, with all our team members, with your medical colleagues, with your intensive care colleagues. I have seen some phenomenal tissue handling, the phenomenal outcomes. So what I was just trying to find out from you is, what is the secret behind Dr. Jnanesh Thacker's magical hand skills or his neurons? What was the secret? We wanted to know.
Well, that's a very interesting question and a very humbling question. Secrets of doing good lung transplantation and outcomes is the first belief is that if we have good outcome and we can show the transformation from what the patient was to what he is now and is able to achieve now on room air and is living his life and going back into his family or to his occupation, to the pulmonologist, that transformation would definitely convince the pulmonologist and the lay people to opt for this procedure. So that passion to have a good outcome is one of the most thing which I think as a team we have been able to build it. Of course, I want to share one story with you. One of my mentor was Dr. Bragg J. Hattler. He was he was a very good senior surgeon, and he and I got along very well. He would always after we finished the surgery, would take me to the 11th floor of our hospital where there was a cafeteria. He would order a big coffee for himself and one small coffee for me. And we would discuss Brahma Vidya. Now, when he was visiting in North India to see the Taj Mahal and with his wife, I invited him to Bombay, and we were in Bombay that evening after his tour. I invited him and his wife for a dinner at the Taj terrace roof, and we were sitting in an evening, and he asked me one question. He said, Jnanesh, what is it that has improved the outcomes of lung transplantation in this world? So I said many things like better anesthesia, better critical care, better suture materials, better preservative solutions, better techniques. His answer was no to all that. He said the three most important things are patient selection, and patient selection. So these are the three most important. So of course, I do follow the guidelines when I choose patients for surgery. The international guidelines have shown in the past that they will improve outcomes. And I try to follow these guidelines and try to, if the patient doesn't fulfill the guidelines, then we give them goals, like a BMI of 14, like the patient that Charan presented. She was having a BMI of 14.7. And then we gave her a goals and she put on weight. And actually, when she thought that she is not able to put on weight, she came to put a nasogastric tube to put on weight. But when we saw her, and on that day a donor was available, we saw that her BMI had increased to 17.3. And we went ahead and did the transplant. And luckily, we had a successful outcome for her. So I think that that is one of the careful patient selection is one of the key things that leads to good outcomes. The donor selection, as you know that we have done, I go for donor selection and then do the recipient surgery. So we select the donors based on 4 criteria. We look at the X-ray chest and see that there is no major pathology on the X-ray like collapse or consolidation. We do a O2 challenge when we put the patient on 100% FiO2, PEEP of 5, and a tidal volume of 8 to 10 ml for a period of 5 to 10 minutes, and then do an ABG. If the PO2 is more than 300, then we think that the lung is oxygenating well. We also like to do a bronchoscopy to rule out any injury, any infection. Now, many a times the infection that we see is not a real infection because, of course, for the patient, for the nurse who is taking care of the donor, he's a dead patient. So her attention will be towards more living patients. So when we go and do the initial bronchoscopy, there are a lot of thick secretions coming out. We clear the secretions, and if we are not sure whether that is purulent secretions, then we wait. We wait for 10 minutes or 15 minutes and then redo the bronchoscopy. If the secretions are still abundantly coming, then we know that the patient is severely infected and we decline that donor. But if the secretions are not there, we go ahead and take this lung if it meets the other criteria. Finally, we do a sternotomy and we examine the lungs by inspection and palpation. We make sure that the lung is inflating. If suppose one lung is traumatized or one lung looks, seems that as if there is some aspiration and there is some congestion, some inflammation of the lung, then we do what is known as differential oxygenation. So we put the patient again on 100% FiO2, PEEP of 5, and tidal volume of 8 to 10 ml. And then we take a sample of a blood gas from the right superior pulmonary vein and one sample from the left inferior pulmonary vein. And we check the blood gas. If the blood gas is more than 300, then still we go ahead and take the lung. This is what we call as differential O2 challenge. So each lung is checked separately. So careful selection of the donor, of course, is very important for improving outcomes.
So, Dr. Thacker, you made a point that we also have seen Dr. Charan, me, our CT anesthesia team, and even our transplant pulmonologist team has seen your meticulous systematic approach for a lung donor selection. So many of the times we also face the challenges related to the recipient list and the sizes. So now you have a good chunk of the waiting list patient system. So you happen to mention me about related to the size, how it actually affects to a male-female ratio, the body's chest wall cavity related challenges. What was that, Dr. Thacker?
Yeah, of course, I have a small dictum in my mind, which I have put it on my refrigerator and I see it every morning. It is that every donor is a good donor until proved otherwise. So if we have a big, robust list of patients like we had in Temple University when I joined, as soon as I joined, there were already 45 patients on the waiting list. And the Temple University, there was nobody interested in doing lung transplant when they recruited me. So when I went and I joined Temple, we had 45 patients, and every day we get 4 or 5 calls of donor calls from all over United States. So we started going and doing procurements and doing back-to-back transplants, that we could do 71 transplants in 105 days, because every donor is good for some patient. So if you have a big, robust waiting recipient list, then we can use almost all the donors that are available to us in some form or the other. Now, the very important point that you have mentioned, Dr. Venkat, is this, that size mismatch. There are several formulas, like there is a European Respiratory Society formula, and there is the Cleveland Clinic formula, which incorporates even age. Other formulas incorporate height and weight, like the European Respiratory Society. Then recently there is a whole review article on size mismatch in the last 2 years, which calculates total lung capacity. Now, these are very good formulas and they may help, but to get a donor's total lung capacity and to match it will be based on predicted values. And this has not been found very effective, and you will always be surprised that either you have a very small lung or a very large lung. So my rule of the thumb is that if a patient has got interstitial lung disease, that means the cavity of the chest of the recipient is about 4 inches shorter than then what would be required. The donor should be at least 4 inches or 10 centimeters shorter than, and preferably a female. But that would be an ideal situation, which is not commonly available. So what we do is of course, it's one of the most difficult things. So what we do is we actually compare the 2 lungs, and then we do a very generous graft volume reduction by actually measuring from the apex to the diaphragmatic surface of the lung and measuring the length of the donor and the recipient, and then tailor it accordingly. Very simple method, which we found that with that we can utilize many, many large donors.
So as you mentioned, every lung may be useful or may be ideal for one or the other patient if you have a bigger chunk of list, which I happen to see in the recent times. Your waiting list is going up day by day into a big list. So you now happens to see every alternative week, or sometimes 1 or 2 in a week, you are getting busy and occupied in the OT. So that's what actually we have seen a change. So the size mismatch which you are quoting, when you have a bigger list, it is easy to fit with one another. So that's the key which you mentioned.
Absolutely,
probably,
yes.
Yeah.
Like for example, recently we had a lung which we could not use for Bhagyalakshmi. We would use it for another patient, like Niteshwar, or a male patient, because the donor was 6 feet tall. And Bhagyalakshmi, our patient recipient, would be 148 centimeters. So things like that, of course, if you have a long list, it definitely helps.
And in the center, where like Yashoda group of organization, already Dr. Swarnalata, who has been a coordinator for Jeevan Dan, who appreciates the whole efforts of Telangana state and also as a group to the Yashoda. We have been also has a that experience of being a unit which actually able to create some good lung donations or some good organ donations program. So that has been also a key component in the whole program, sir.
Absolutely, absolutely. That is one of the key things that Yashoda Hospital and with its 3 branches, they have almost converted lung transplantation into an elective operation. And I'm deeply grateful to Dr. Pawan Gorakunti and the Yashoda management and to your team for taking such excellent care of donors that we have we have real pleasure in going and doing this, retrieving these organs and doing this transplant. It is an awesome thing. I don't think such a situation exists anywhere in the world. I would be surprised if there is a replica of this Yashoda transplant program anywhere in the world.
So we were also very happy as a team of intensive cares who are managing this organ donors, brain dead organ
you are
donors.
doing an amazing job. Amazing.
So the reason, sir, is initially when these programs all started, we used to actually have an opportunity probably for cornea, renal, and liver. They used to end the organ harvesting system or organ donation. The other organs used to be unutilized and when buried or burned. But now we are seeing more and the more organs, including the lung and the heart, being also been utilized for some or the other needy patient, which is more gratifying than what we used to happen earlier time. Now, because of the organ crosstalk, we have our own challenge of managing all the organs. Earlier, we did not used to bother about a volume overload state or a little a wet lung. Now we are trying to manage or balance between your heart, lung, and kidney and liver, managing the all organ perfusions and not actually inclining to one another and balancing act.
Thank you, Venkat. You are doing a great job for lungs. So, thank you so much.
Other component, Dr. Jnanesh Thacker, is related to the common condition with which we come across. So what are those common patients' clinical conditions or indications with which your patients are flying to you or reaching to you? We wanted to know that.
The commonest, 3 commonest indications for lung transplantation in our country are, first is ILD. Almost 80% to 90% of the patients, in fact, we have operated most of our patients, almost 90% of our patients have been interstitial lung disease with or without pulmonary hypertension. Then the next common is bronchiectasis. And the third commonest is idiopathic pulmonary arterial hypertension or primary pulmonary hypertension. COPD, I have had only 2 patients being referred to me in this last 10 years or 11 years for surgery. Sadly, both of them before were too old and could not get operated because of many other comorbid conditions. So the primary indication is interstitial lung disease. And
so what is the chunk of that which goes to interstitial lung disease among that?
See, we try to do double lung on all patients. As a rule, interstitial lung disease, if the patient is very, very sick and the patient does not have time to wait for another donor, and we have a donor at hand right now available, but one lung is badly destroyed or infected, badly injured or infected, then we take the other lung and use a single lung for transplantation. But this is when a donor cannot just wait for another donor, when the recipient cannot wait for another donor, when we think that he is so sick that if we operate him today, he might survive and may get back to normal life. Otherwise, we try to do a double lung for almost all patients. Now, if a patient is, say, 70 and above, 70 or above, then we can give him an option of a single lung transplant. There is one patient who needs like that and is waiting. but his family is still not very convinced that they should undergo a surgery because he is almost 70 years old.
I was just trying to know from you, sir, what is the percentage of ILD in this the list of indication? What is the percentage of the cases which are ILD to a transplant?
In our practice at Yashoda, almost 90% is ILD, 5% would be bronchiectasis, and another 5 primary pulmonary hypertension. Once the cardiologists also get convinced that the outcomes of primary pulmonary hypertension will be good once they are in NYHA class 3 and 4, then cardiologists can also start referring these patients, because double lung transplantation and heart lung transplantation have shown over time equal midterm and long-term results.
So we have a question from your colleague, Dr. Raman Ramana from Vizag. He asks about bronchial anastomosis and your experience with omental patch, I believe, and the technique of your bronchial anastomosis.
Yeah, I use a single suture, bronchial anastomosis. I use a single suture. We begin with the junction of the membranous and the cartilaginous part. And I use 3-0 proline on an SH needle, which is 75 centimeters long. I make loops and then I tighten those loops slowly and do a single suture technique. If there is a gross mismatch, I try to adjust the mismatch on the membranous side and and I try to avoid I don't do any revascularization with internal mammary artery to the bronchial artery. I don't put any omental patch, but I definitely put the pericardium from the donor to the tissue around the around the bronchus. And I do I cover the bronchial anastomosis with the adjacent tissue. Also, I see that I do minimum dissection in the recipient. I don't dissect out the bronchus. I just transect the bronchus with the mediastinal tissue and the lymph nodes. I think with these 2-3 points, he will find, Dr. Raman will find that his anastomotic dehiscence will be reduced significantly. That is what I've been trained and that is what I've done. And I find that is really helpful.
Dr. Charan, there are some interesting questions. What is the learning curve you need for a lung transplant intensivist or anesthetist? You can answer intensivist. Do I have Dr. Ravi on board somewhere? Pawan, can we see Ravi? Dr. Ravikant?
One moment, sir.
So Charan, you can answer the initial part. What is the learning curve for becoming a transplant intensivist? You have been working for the last 2 years in the transplant intensive care unit. So what was your learning curve?
So I would say that I am extremely lucky for having excellent teachers around me who taught me very well in actually managing a patient of lung transplant. So before I actually went in, I've joined intensivist in this unit of heart and lung transplant. Frankly, I did not have any experience in managing lung transplant or a heart transplant. So it's the transplant pulmonologists, the transplant surgeons who have actually guided me at every step. A discussion-based approach. So I would say I was lucky, and it takes a little time for us to actually completely apply our critical care principles, because this transplant critical care requires much more basic applications into to the patient. As Dr. Jnanesh Thacker repeatedly says, it's the clinical judgment which plays a very important role in guiding these patients, in differentiating whether it is rejection versus infection. So there are certain gray areas in identifying when it really comes to the clinical course. But we can learn transplant. We can learn the
It is mutual learning. It is mutual learning, Dr. Charan. I keep a learning attitude. I learn so many things from you, and whatever I have picked up I come to try to do rounds before you come for rounds, so that I do all system-wise analysis and I lay it out before you, so that if there is anything that that, so basically I tell myself, you are his houseman, just do everything and keep everything ready so that when he comes, he will know all the issues and he will pick up all the parameters which are going haywire and correct them. And then we discuss and we are happy that the outcomes are, see, very sick patients have turned the corner and they are doing well. That has been a really great learning experience.
Yeah.
Thank you, Charan.
Dr. Ravikant, can you unmute yourself? Dr. Ravikant, there are questions to you. What is the learning curve to be a transplant anesthetist, particularly lung transplant anesthetist? Can you hear us? So there are other questions, Dr. Jnanesh Thacker, that how good is off-pump lung transplant?
I think that off-pump lung transplant is a very good for patient, though it is strenuous for the surgeon and more strenuous for the anesthetist. If Ravikant did not have nerves of steel, then I don't think we would have succeeded in doing so many off pumps, because the left lung hilum is behind the LV. So luckily that, although we try our best, and I have an excellent surgical assistant in Dr. Kamran, that who does dynamic retraction. So every time I have to take a stitch on the on the recipient bronchus, he retracts that much as I can see the point where I have to put the needle. And even then, we do lean on the left ventricle so often that you need a very calm anesthesiologist. So with Ravikant and Kamran, it is possible to do this difficult operation. It is very patient friendly. The patient can get extubated within 72 hours and can be discharged without a single blood transfusion, as some of our patients have gone home by the 11th day. In fact, the team is very insecure about discharging them so early. So we discharge them 5 or 6 days later and keep them so that they learn much and we all feel comfortable to discharge them by the 14th or the 17th day. This, I think, would be not possible if it did the surgery on any other support like ECMO or cardiopulmonary bypass. Of course, meta-analysis of 7 studies have shown that cardiopulmonary bypass has now been replaced by ECMO, VA ECMO, which is being propounded by the Vienna group to be used routinely in all patients. It is good, but there are certain damaging effects of cardiopulmonary bypass when the blood comes in contact with the oxygenator. Very many cascades are activated, like the bradykinin, kallikrein, the coagulation cascade, the fibrinolytic cascades. All these lead to increase in capillary permeability, which causes pulmonary interstitial edema and edema all over. So I use ECMO only when there is severe pH or when we cannot have adequate exposure. Of course, we keep a low threshold for opting for VA ECMO.
Yeah, we will take still now Dr. Ravikant's opinion on that. Can you unmute Dr. Ravikant? Please unmute yourself, Dr. Ravikant.
Yeah, can you hear me?
Yeah, Dr. Ravikant, there was questions related to the learning curve for a transplant anesthesiology. So you have been a heart and lung transplant anesthesiologist for the team Yashoda. So what was your learning curve? There were many questions related to, is 50 years is an appropriate age to get into a transplant anesthesia, and which is the right place to train with them?
See, cardiac anesthesia is like entirely different from a transplant anesthesia. Transplant anesthetist should have a lot of patience, and he should know what the surgeon is doing every step. And one more thing is, induction of the patient is the main goal of the patient outcome. If you do anything wrong in the induction of the patient, handling in the ICU, taking him to the ICU, stabilizing him, putting on single lung ventilation, putting on a pulmonary catheter, and knowing its pressures, handling the PA pressure with nitric oxide, and most important thing is your induction. Main over the induction, you need to keep the sympathetic tone of the patient. If the sympathetic tone is gone, your patient, I seen one patient from just 1 mg of midazolam has let the pressures come down from 170 to 60. That's how the roller coaster blood pressure falls down in this lung transplant. The reserve for them is very, very less. So you need to be very cautious on your toes every time, and you should be capable of putting immediately in case you need to go on ECMO. You have to be capable of putting an immediately double cannula and go on ECMO and resuscitate the patient. That has to be there, and you have to be trained as an ECMO specialist also, because in case if there isn't your time and the surgeon is busy in retrieving the lung, you should be helping a surgeon to put him on an ECMO immediately, because the reserve for these patients is very less. The only good part of this, or the lung transplant I learned, is how maximum patience you can learn, and it's really tough handling these patients intraoperative. And don't fluid overload them. It's like give very guarded fluid and reserve your fluids only when needed, and avoid as much as you have to be reciprocative with the surgeon every step what's happening. I think that is a goal, and the main goal of this is your induction of anesthesia and handling the patient perioperatively before induction, and putting him on a single lung ventilation. If it's not possible in single lung, if not, you can use a bronchial blockers, and initially measure your peer pressures. Accordingly, the game plan starts. Every patient is entirely different for every game plan.
Okay, thank you. Do we have Dr. Hiral on board anywhere? You can just check.
One moment, sir, checking.
So Dr. Jnanesh Thacker, Dr. Sri Charan, Dr. Ravikant, I can see the whole team here. I think the interventional pulmonology team, or the team, the transplant pulmonology team, is busy occupied with their programs in the city of West Bengal. So we will bring them some other day. But how important it is, the teamwork. We are talking about a referral system, appropriate patient referral from a department of pulmonology, proper appropriate evaluation, selection of patients, selection of donors, then preoperative evaluation, preoperative, you said optimization, intraoperative handling, then sir said off pump, on pump handling, then post-operative issues. Charan said there is a lot of complexity in learning. So what is the teamwork role? Dr. Charan, what is your comment? Charan, on board? So Ravi, what is the teamwork role you
actually the teamwork starts from the preoperative to the patient. First of all, counseling the patient. The patient should know what she's undergoing, what trouble she has, what problem she has, and every step. And the surgeon and the anesthetist, the physicians, the critical care specialists, everyone should be aware with the patient. They should be friendly, and they should be aware whom they're talking to. And it's like everyone interacts with them in every step. Okay. And that makes a wonderful counseling. And one more thing is, the preoperative evaluation starts as early as possible. Once the patient is on a very low oxygen, in Indian scenario, the problem is patients want time. The time, once you waste the time here.
Dr. Ravi, I'll come back to you. We have Dr. Yoshida Toyoda. Sir, welcome you on board. Sir, can you unmute yourself? Can you switch on your camera, sir?
Can you hear me?
Yes, sir. What a pleasant surprise to us, sir. It's an honor and privilege for all of us to be a part of the same webinar where you are there, sir.
Hi, Yoshi.
Hi. Yeah, Dr. Thacker asked me to join this one. So yes. Thank you.
So, Dr. Yoshi, Dr. Thacker here doing a lot of lung transplant and making a huge amount of noise or a visibility in making a lung transplant a visible, viable, and a happenable event right now in India. And last week or 10 days, it happens to that in the month of April, May, there were around 5 lung transplant happening in our unit, and 3 are on the verge of getting recovered and getting discharged. So here is a team of the transplant team. So Yoshida Toyoda, being a mentor and being a part of the Temple University transplant team. So we just wanted you to express how this lung transplant program from the last probably few decades, you're taking the lead in that program. So what's happening with the Temple University, or how is the transplant program being on there?
I was listening from the start, and I was very impressed with your team.
So you are there on board. We could not see you.
Oh, you can't.
No, we are now able to see you, sir. Now you are able to see you.
Oh, okay. Yeah. So I was I was here from the start, and then I saw that 8 successful cases, and all are very sick, and your team did excellent work, I think. And I was just listening discussion also, so I can make some comment.
Yes.
So the tempo, you know, the literature suggests we should do double lung, but if you have a two surgical team, we try to do single lung, probably 2/3 of the transplant, so that we can help 2 patients instead of 1 patient. So the IPF or the COPD, we try to do 1 lung. Even sometimes idiopathic pulmonary arterial hypertension, if the lung chest cavity is big, sometimes we do 1 lung.
Okay.
And yeah, we are at AATS meeting right now, you know, American Association for Thoracic meeting. So my research fellow reviewed the UNOS data, and we found, you know, single lung followed by single lung contralateral single lung later versus double lung looks like no difference. So, and also, you know, the single lung, you can put little bit oversized lung to the 1 chest cavity, whereas if it's double, too big sometimes. So that's one suggestion.
Sir,
then,
yes, sir. We wanted to know from you the lung transplant during pre-COVID and COVID. And what was the difference in the COVID pandemic and COVID lungs particularly? When you actually done a lung transplant in COVID patient, what was your experience?
Most of the COVID patients, they had a baseline disease. You know, they pick up COVID, then they now become oxygen dependent and continue to get worse. So most of the COVID such patients are just the same as regular ILD, but extreme patients like ECMO for many days, those are really tough. Yeah, we noticed lots of adhesions in the chest cavity usually, so the dissection is tough. So that's the difference.
The patients who stuck on a kind of ECMO for a longer period, there is no scope of their recovery, and you know, there's an end of road, so they went for a lung transplant. In those cases, when you, how many cases you have done lung transplantation, what happens to the outcome of these patients? They were very complex and difficult cases.
Right. So real COVID ARDS on ECMO for many days.
Yes.
Those have a long recovery time, although they are surviving, but the hospital stay is long. But the other, you know, just a little bit of COVID is the same as other transplant.
Okay, so it remains. We are trying to ask you the patients who are ARDS, COVID on ECMO going for a lung transplant, and those who actually recovered from COVID but went on to the fibrosis and probably end stage lung disease. You said they are more mimicking like your old age ILD, but the ARDS patients who actually were on ECMO had a difficult prolonged stay, but the mortality remained to be the same like ILD.
So far, as of November last year, I think I presented at the maybe Indian meeting at the other one. We did a 16 lung transplant for COVID-19 as of November last year. At that point, everybody was surviving, but clearly patients on VA ECMO pre-op takes you know, many days, 1 month or 2 months before discharge.
Okay. What were the common challenges there in Temple University? We had a country where the pollution, infections, and endemicity of tuberculosis, and probably the sensitivity of hygiene practices have been a challenge. But what are your common infections? I wanted to mention the infections or nosocomial infections, XDR, MDR, bugs in Indian context, because the antimicrobial use at the grassroots level even in the smaller tier 2 cities or at the village levels has been rampantly high. So this makes a lot of complexity in infections also. So what is your side of complications in what you face with your lung transplant in Temple University?
Donor infection is, as Dr. Thacker said, we check with bronchoscopy if it's repooling with lots of purulent secretions, and then visually, if there is a consolidation, we consider that as a pneumonia, so we decline for that lung. Maybe contralateral lung may be usable. As Dr. Thacker said, we check pulmonary vein blood gas or 4 pulmonary vein blood gas. Yeah, but infection usually not the issue in the, sometimes histoplasmosis, they're calcified nose, we take it. But we check with the ID, transplant ID, and then they sometimes say don't take it. Yeah.
Okay. And how do you see, Dr. Yoshida, the transplant program in India? You have been pioneering there for the last few decades. So Dr. Thacker initiated this in the last couple of years or so. So how do you see the lung transplant program in India and its prospects in the future?
I don't know the big picture, but I participated. This is the 3rd meeting since last fall in India. I feel lots of interest, and everybody's hard work to save patients. And of course, India has a huge population, so I'm sure India will exceed US for the lung transplant volume eventually. So I feel enthusiasm from the Indian physicians and surgeons.
Okay.
Dr. Venkat, I want to seize one opportunity to thank my mentor, teacher, everything that I know about lung transplant and heart transplant. I have learned it from Dr. Yoshi, and I want to express this gratitude to him for, like he said, the first time I did waiting for pooling was done with him. The first differential oxygen saturation done, I did it when he was the senior person who was guiding me through all these steps. I deeply express the gratitude for all that you have taught me, Yoshi.
And anesthesiologist just talking about induction time is very critical. That's totally agree. And many times we start epinephrine drip before inducing patients just to maintain the sympathetic tone. And we have a femoral line kit in our hand. While patients still have pulse, we want to put a femoral air line at least, if such unstable patient. Yeah. And still our Temple program, the anesthesiologist intubation, obviously we need to be very gentle. We had a tracheal tear with a double lumen or perforation of the bronchial membranous portion with a bronchial blocker. So anesthesia is also critical. But once you do pneumonectomy, you can see the bronchus. So surgeon can guide anesthesiologist about blocker and double lumen too.
Dr. Jnanesh Thacker, you wanted to ask or?
Yeah, I want to ask Yoshi 1 or 2 questions.
Yes, sir,
he
please.
gave one suggestion, which was very unique and which is new knowledge, that you can do a single lung for a patient, and then after a period of time, if required, you can do the other lung, and the outcomes are same as that of double lung. That is very fascinating, and it is a paradigm changing data which you have shown to us. What I would like to ask you is, Yoshi, is what are the other things? You are mentioning something when you got interrupted from your new experience, that what are the other things you are mentioning from the UNOS data that you all had analyzed?
You mean a single lung followed by contralateral single?
Yes.
Versus double lung.
And then you were mentioning something else also.
Did I? But this bronchial anastomosis, I modified it. Any surgeon has complication, right?
Yes.
And I modified before sewing. I put 3-ioproline SH as a stay stitch, in the middle of the cartridge portion and then lift up. Before we were using it like a silk stitch, right?
Yeah, we were using silk, yes.
For the posterior suture line, but I use a 3-O-Prolene. And then left corner, cartilaginous and membranous portion border, I put a 3-O-Prolene SH stay stitch also. That will stretch the posterior suture line and you can space easier. Also, at the end, there is an interrupted suture at the left corner and then middle. So there are 2 additional interrupted suture. By doing this, we were able to, minimize the bronchial issue. Yeah.
Thanks a lot, Yoshi. That's a very valuable thing because I still continue to use the black silk single stay suture. I will now switch on for the next case. To this
once you finish the membranous portion, you can put this stay stitch to the donor bronchus at the middle portion, so that middle portion and the corner, so you can space easier.
Dr. Yashoda, what are the common indications which you come across in Temple University for this lung transplants? Like Dr. Thacker was talking about ILD being a predominant the conditions here with the 90%. So what was the Western context?
Temple about 70% ILD and probably 20% COPD, and then 10% PH or the bronchiectasis, those, yeah.
So what was the single lung and how many were the both lungs transplants common there?
So our data shows about 2/3 single lung. So many times we do 2 single from the 1 donor.
Okay, 2/3 as the single lung.
Yeah.
That's
we changed the paradigm.
Yeah, it's a paradigm change since what we
right.
How many of the times it is off pump? How many of the times it needs an ECMO support in these patients, or it depends on the clinical context?
Right, that depends on the surgeon too. The careful surgeon, our team, many surgeons, probably except me, they open the groin at the beginning and expose the femoral femoral artery and vein, just in case they need to go on VA ECMO. That's a safe approach. Of course, there's a lymph seal or some complication can happen, but that's safe. You don't have to crash to the pump. But when I usually cannulate centrally, even left lung or right lung. So I do almost all aortic cannulation from the chest, and right chest, probably right atrium, and then from the left side also you can put the right atrium, but femoral venous line may be easier. So those you need to prepare for the pump also.
That's why, sir, for to make it more comfortable for my surgeon, always I keep a femoral artery and femoral vein cannula ready, because just to put a guide wire and just put it on a dilatation and go on ECMO. I keep a femoral vein and a femoral artery always available for my surgeon for every transplant.
Yes, that is a great help, Ravi. To have my genuine
any comments
thanks
from Dr. Charan to Dr. Yoshida Toyoda. See, we have been listening about Dr. Yoshida Toyoda from Dr. Thacker and probably all those guidelines, documents, and all that which you used to share with us. So anything, Dr. Charan, from your side? Dr. Charan is being our intensive care specialist who is looking after our perioperative cases. So Dr. Charan, can you unmute yourself?
Hello, sir. So, what is the general course of the patients in your ICU in these patients? What is the general or average period of mechanical ventilation days, and how often do you actually see primary graft dysfunction in these patients?
Usually, we extubate day 2 if everything goes well. Depending on the time of surgery, sometimes day 1. But my colleague, Dr. Shigemura, he managed the patient, and he feels probably we should not extubate too early, but wait for like two days or so. So mostly day 2 usually. Yeah.
And Primary graft dysfunction, how frequently we come across it?
Primary graft failure requiring ECMO?
Yes,
That's probably about 5%.
Primary graft dysfunction, how often do you see in your patients? Like, am I audible?
So probably 5 to 10%, I think, require maybe ECMO post-op.
Okay.
Dr. Thacker, sir, you can just
requiring ECMO would be PGD grade 3. That would be
Right.
PGD grade 3.
Right.
That would be about 5 to 10%.
Dr.
You
Thacker,
still do, Yoshi, you still do the enteroaxillary approach that you trained us to do?
Yes. Yeah.
And you still do most of your cases off pump?
Yes, I do.
First choice off pump, right?
Yeah. So before starting the pneumonectomy, we hyperventilate for both lungs, donor lungs. And then once we put the one lung down, we do quickly. So then mostly you can do off pump even for moderate pulmonary hypertension. But of course, VA ECMO is safer.
Dr. Yoshida Toyoda, you spoke about the challenges of availability of lung and making it one lung to one patient and making them survive, waiting for another lung to get transplanted. What about the donor borderline conditions where you have a trauma, contusion, some mild aspirations and all? So the selection threshold, is there any alteration in the selection threshold in the recent times? We know the organs availability is a big challenge.
For the donor.
Yes.
So the bronchoscopy, as I mentioned, it's a repooling purulent secretions with a consolidation of the lobe. That's usually we decline. But otherwise, of course, if there's an emphysema in the donor lung, like older donor smoker, then we decline. But otherwise,
trauma, contusions.
Depending on the size, I think. Size. If it's a small trauma, then
what is your cutoff PF to start with?
PF ratio?
Yes, cutoff PF ratio.
So in the ICU, many times PF ratio is 150 to 250, but once you open, usually 450 to 500. So if it's a young donor and it looks good, based on the CT or the X-ray, those lungs must be good. So that's we go and open and check. Usually those are good lungs. Yeah, so PF ratio for the young donor, not much. Yeah, but once you open, of course, PF ratio matters. Once you correct all the atelectasis, no shunting, then PO2 is 250, then that's little marginal. Yeah.
So Dr. Jnanesh Thacker, I think it will be your privilege and honor to actually thank Yoshida Toyoda on this program so that we can conclude.
Yes, I am deeply grateful because what I'm doing in the last 10 years, I am doing exactly what he has taught me. And today he has given me 2 more important points about bronchial anastomosis based on his profound experience. He was the director of the surgical program of the largest program for more than 5 years. And today also he runs one of the largest programs in the United States with the best outcomes. I think he's a great mentor for me and for many, many other surgeons like me all over the world. So I deeply express my gratitude to Dr. Toyoda, and I wish him all the good and the greatest success.
There was a question related to the phrenic nerve injury. Precautions to be taken during the recipient's handling of the diseased lung.
I think they can put a diaphragmatic stitch for that.
Dr. Yoshida Toyoda, they were asking about phrenic nerve injury in the recipient lung. During the recipient lung retrieval or removal, the phrenic nerve injury, what are the precautions to take to avoid the phrenic nerve injury?
Yeah, just don't touch the phrenic nerve. That's the only thing. We use a sponge stick like a peanut to gently retract the pericardium. And then we incise the pericardium under the phrenic nerve and just extend the pericardium open. Usually phrenic nerve is not an issue unless redo lung transplant, severe adhesion. primary transplant should be good.
Okay.
So stay away from the clinical. Yeah.
Thank you, Dr. Sia, and thank you, Dr. Thacker, and thank you, Dr. Charan, for your presentation, and thank you, Dr. Ravikant, for your availability. I thank all the participants who actually were actively participating for questioning both the panelists. I think I thank both of you for sharing your wisdom. It's an honor and privilege for all of us to share the screen with both of you, Dr. Yasia and Dr. Thacker sir. Thank you for all joining us. Thank you.
Thank you,
I
Yoshi.
conclude the session.
Thank you.
Thank you, sir. Thank you.
Thank you.